Hello, and welcome back to Infant Feeding Alliance podcast, where today we're going to dig into the evidence about skin to skin contact. I don't have a guest today. I have a friend and partner in crime, Sue Haddon. She is the organizational force behind Infant Feeding Alliance. And so today we're really talking about our experiences as mothers who gave birth in the UK within the last 10 years. With skin to skin contact, and everything we say in this podcast, we say as mothers and as people. It is not professional advice.
We should say you are a clinical psychologist with a PhD in developmental psychology.
Yeah, that's true. And this is not a matter of a couple of moms going and doing some Google searching. This is a couple of moms digging into the Cochrane review, looking up the original evidence that went into those reviews and the evidence behind the recommendations our healthcare providers are making. Some people have been in touch with me asking, what can we do to support your podcast? Well, there are some really simple things you can do if you want to support us and help us to grow. They're really, really easy. Hit the like button, subscribe, and leave a comment on this video. So, Sue, let's talk about skin to skin.
Yeah, I just think we need to start by being really clear what we're talking about when we talk about skin to skin, because most parents who've had a baby in the last 2 decades will know what we're talking about, but others might not. And we're not just talking about practices of holding your baby and kind of what you want to do after your baby's born. This is an intervention, and it's written into clinical guidelines, and all parents with a healthy term baby will be recommended this intervention. So it's part of the Baby Friendly Initiative, or as we like to call it, the so-called Baby Friendly Initiative. And what it is that as soon as the baby's born, as long as it's in a good enough condition, I should say the condition of the mother appears to be immaterial. As long as you're basically conscious, you'll be expected to do this. And it's the placing of the newborn baby naked against the mother's naked chest, prone, and there are lots of claims about why we would do this that you're going to go into, but the main one is that if this is done for at least an hour uninterrupted, the baby will on its own find the breast and establish breastfeeding on its own. So there's very much this idea that modern medicine, modern healthcare settings and ways of life have interrupted some processes around birth, natural processes around birth, and we need to bring these back. So Baby Friendly say about this process, when a mother holds her baby in skin to skin contact after birth, it initiates strong instinctive behaviours in both. The mother will experience a surge of maternal hormones and begin to smell, stroke, and engage with her baby. Baby's instincts after birth will drive them to follow a unique process which, if left uninterrupted, will result in them having a first breastfeed. Now, they also make a number of more kind of health type claims that skin to skin stimulates digestion, it regulates the baby's heart rate and breathing, helping them to better adapt to life outside the womb, enables colonization of the baby's skin with the mother's friendly bacteria, regulates temperature. So there are all these claims and this big kind of story around immediate skin to skin contact.
Yeah. And we should also say that what we're talking about here is skin to skin contact for healthy term babies. There's actually very good evidence that skin to skin contact in a neonatal intensive care setting for very premature and sick babies has a number of important benefits. I'm not going to go into those, but that's a very different population. That's a population where babies are in intensive care beds, they're monitored, they've got monitors on them. Parents in that setting can't just spontaneously pick up their baby. Their baby's really too medically fragile for that. So it needs to be supported by healthcare staff. The baby needs to be monitored. And when we spoke to Clay Jones in our last podcast episode, which we will link to at the end, he was emphasising that the NICU nurses watch the babies like a hawk in that setting and how closely monitored they are in skin to skin contact. And I think that's that is such a different setting because of the medical fragility of the babies, but also because parents just can't spontaneously pick their babies up and do what any of us really want to do with our babies, to hold them and touch them and stroke them and interact with them, is just much more difficult in a NICU setting. So we're talking about healthy term babies, and I think we need to say that really, really clearly. So, I mean, before we dig into the evidence, what was your experience of skin to skin?
Well, the main thing to say about my experience of the moments around my daughter's birth were that I was extremely sleep deprived. I had a long latent phase of labour and I had contractions for a week. So I really didn't sleep hardly at all for a week, certainly not at all for 3 nights. So by the time she was finally with us, I was really in a very sleep deprived state and exhausted and quite low in mood. So she was handed to me. I probably consented. I don't really remember, but there was certainly no discussion or sense that there was another way to do things, or that, her dad could hold her, or we could put her in a cute sleep suit. It was very much, you are doing this now. And I looked at my notes in preparation for this, and it looks like I did skin to skin for about 2 hours. So I should get some baby friendly award for motherhood. Just kidding. And really, all I remember during that time is, when do I sleep? When do I sleep? Recover, restore myself for the challenges ahead. Of course, I wanted to meet my baby, and particularly after the ordeal she'd been through as well, I, was so relieved she was well, and I wanted to see her, meet her. Of course I did. But almost immediately after that, my thoughts turned to my own need for sleep, and it was just very clear from the staff's attitude that it wasn't time for that. I still had a job to do, and I mean, of course, you have a job to do when you have a baby, but you also need to.
But you need to be well enough to do that job.
Mm-hmm.
You need to sleep. You need to eat. You need to potentially have medical treatment after your baby is born, because you might not be so well.
You might want a shower.
Which is exactly what I wanted. So when my baby was born, the first thing she did was pee on me. The second thing she did was poo on me. And I, like you, had a very long labour. I think when she came out, I was buzzing. I was running on adrenaline. So I didn't have that sort of urge to sleep, but I was in a considerable amount of pain, and I was quite shaky, which is not really surprising. I'd just been awake for several days, and this long painful labor, and I asked my partner if he would take the baby, and it didn't occur to me. I think the kind of narrative on skin to skin had passed me by. I didn't see it as a big deal. So the indoctrination hadn't got to me. And I asked my partner if he could take the baby. That just seemed to be the most sensible thing to do. And it was actually really nice for me to just watch him meet her for the first time, hold her, interact with her. And, just to see him enjoying that moment. And as soon as I did it, the midwives started shouting like it was a medical emergency, like, take your top off, you've got to take your top off. And he was just startled, like, what? And he did, he complied, he took his top off, and he's there holding her on his naked chest. But it was just like, what's going on, that you feel like you could just start shouting at a man to strip in the delivery room.
Like the Chippendales or something.
It was, and I was a bit like, oh my God, have I just given birth, or am I in like a dodgy Soho club? It was, it was really quite absurd. And I think I just wanted a shower. I mean, it was disgusting. I hadn't, I'd been in the birth pool for quite a long time in labor, and birth pools, when you're in labor, things come out, let's just say you don't come out feeling like you've had a nice bath. And, I was sticky, I was smelly, I was sweaty. I just wanted a shower. And it was like, what a monster that I would want to get up and go and have a shower.
So you were the rebel and I was the good compliant girl.
That's probably a bit of a theme. That's probably a theme. I didn't do it, and I did think they were really quite ridiculous, and I did laugh about it for quite some time to come, particularly calling my partner a stripper. But there we go.
So there's this Cochrane review of the evidence into skin to skin that you're going to go into in more detail. So this was studied quite recently. I mean, how do we get here? Why was skin to skin studied?
Well, it's interesting. So just to kind of say what a Cochrane review is. So Cochrane are an organisation that look at the evidence behind different interventions or different practices with a view to making healthcare recommendations. And what they do is they systematically review the entire literature, and they have kind of very systematic ways of doing that. And really, this is probably the best way we have to figure out what actually is effective and safe patient care. But, look, the same rules apply with Cochrane reviews as anything else: garbage in, garbage out. So you also have to look at the quality of the studies that's going into those reviews. And Cochrane are supposed to do that as part of their own processes, look at the quality of the evidence, rate it, grade it, and really determine what grounds there would be to make a healthcare recommendation. Because when healthcare professionals are advising patients, they're giving professional advice that patients will take seriously on the whole. So there needs to be a strength of evidence that that what you're telling a patient is most likely to benefit them, and that they also know the potential risks involved so they can give informed consent. So that's the point of a Cochrane review. Now, the Cochrane review of skin to skin is carried out by researchers who are advocates for skin to skin. They see it as a positive thing. That's quite evident in the review. That's also evident in their other research and things that they say. So they're going into this, I think it's fair to say, with a level of favorability towards skin to skin. And, in the interest of full disclosure, I think I'm going into this with the opposite bias, in the sense that I don't think skin to skin is any great shakes. I actually think, I found it an intrusion to be kind of being given this advice. And I look at experiences like what you had and think, is this really realistic? I mean, maybe people might like to do other things. It's not the only option available. And should it be advised over other options? I'm not so sure. And by options, I also want to be clear, I don't mean medical options. I mean just different ways that parents want to relate to each other and to their baby, and want to experience those early moments. I think there's endless ways that families could do that. Should we be advising anything in particular? Where the Cochrane review starts is exactly what you said. It's with the idea that skin to skin, and they're very clear, this is about holding a baby. The baby is naked, the mother's breast is exposed, and the baby is placed in a prone position on the mother's breast immediately after birth. And the reason for this, they say, is because this is the evolutionary norm. This is what other species do, and that it is with 20th century industrialization and medical interventions have come to interfere with this process, and they particularly highlight practices in hospitals that are no longer in place in any UK hospital of separating mothers and babies at birth, which they see as really interfering with these normal biological processes, and that basically we need to now make a recommendation of skin to skin as a clinical recommendation, even though it is seen as a kind of evolutionary norm.
So this is sounding quite a lot like normal birth ideology, which we know to have been implicated in deaths of babies and mothers.
Yeah, exactly. So it is essentially normal birth ideology applied to the early postnatal experience into breastfeeding. It's the idea that certain things are natural and normal, and that those are preferable. So it's what other scientists would call the naturalistic fallacy, which is that which is normal and natural is healthy and good or pure. And so, as you and I know, in the UK, there's been numerous maternity scandals, and there's a repeated theme in independent investigations that the pursuit of normal birth and avoiding things like doing a cesarean section in labour are leading to very serious harms to babies and to mothers, and in some of those cases, far too many of those cases, the harm is death. And so this is really being highlighted as a serious issue in UK services, and all of our professional bodies, so the Royal College of Obstetrics and Gynecologists, the Royal College of Midwives, along with groups like the National Childbirth Trust, amongst others, really enthusiastically embraced and advocated for normal birth. And I think, reading this, it looks like the advice around skin to skin is a continuation of normal birth ideology. So there is our first problem. This is not a scientific theory to begin with.
So what is the evidence behind this theory? Skin to skin as a natural process, the mammalian process that babies need.
Well, the evidence they cite in the introduction to the Cochrane review, so this is kind of building up a picture as to why this is worth looking at, why this might be an important thing for clinical research and clinical recommendation. They cite a lot of evidence about infants being separated from their mothers, crying for extended periods, having reduced hippocampus sizes, not developing their full intellectual functioning, and really being impaired for life. But all of these studies are carried out in rats. Right, so a lot of the evidence here is like, we're doing these rat studies, and that supports our theory that mother-infant separation is a terrible thing and has lifelong consequences, and consequences for brain development. I mean, it's fair to look at animal studies and to think about what they may mean for human biology, but I don't think you could just take from rats and apply to humans. What they then go on to cite, and I think this is a little more subtle, they reference Stephen Porges, who proposed something called polyvagal theory, which essentially proposes that human beings have kind of two levels of processing. We have our kind of lower early evolutionary level, which is fight or flight, and we have a higher level of processing where we're calm, where we're soothed, where we're connected with each other. It's a very simplistic idea about how human emotions work. And there's also a lot of kind of neurobiology and stuff about hormones around this that is proposed. And there's really no evidence to back up the claims made by polyvagal theory. And in fact, there's quite a bit of evidence that goes against the claims being made. I will put a link in the description to a very nice basic article explaining why polyvagal theory really isn't a plausible or credible scientific theory. But what it is it's a clever sounding theory. Okay, So let me give you an example of some of the language and the words used around skin to skin. So it says when operating in a safe environment, that's from polyvagal theory. When we're safe, we're able to regulate and we're able to connect with other human beings. Oxytocin and direct skin to skin stimulation of vagal effects, that's referring to the vagus nerve in the human body, are probably part of a broader neuroendocrine milieu.
This all sounds very sciencey. I'm thinking of Ben Goldacre's kind of, what does he say? Sciencey sounding words.
Bingo.
But are you saying this isn't?
Yeah, this is like, it's drawing on, it's kind of interesting, and it draws on a kind of, it goes from a naturalistic fallacy to rat studies to kind of pop psychology combined with a bit of neurobabble. This is not credible scientific theory, in my opinion. And there's just so much here. It's just like, it sounds really clever, but to describe holding a baby, it's a bit much. It's a bit much. And, you know, it just isn't, you know, this research and the polyvagal theory that this is based on is just not credible.
So what did the Cochrane reviewers find when they looked at her evidence for skin to skin, and what kind of evidence did they look at?
Well, compared to the theory and the claims that are being made and the way that it's put across, the actual evidence is far more modest. And the researchers actually do acknowledge that. They do acknowledge that the studies that they found are pretty methodologically weak, and they're small studies. And what they did is they looked at comparing in healthy term babies, although they also ended including some later preterm babies in the study. So this is not just one population that we're looking at. And the studies are carried out kind of between the 1970s to the 2000s. So quite vastly different practices in healthcare between the 1970s and the 2000s. So in the 1970s, for example, they would have had newborn nurseries. In the 2000s, certainly in the UK, we do not. Also, breastfeeding promotion in that time period has gone from really not being a big emphasis to being almost the singular emphasis in postnatal care. You know, so things have changed. It's also, the research is also carried out in different contexts. Some of it is carried out in the UK and the States. Some of it is carried out in Nepal. And they look at very different durations of skin to skin. So in some of the studies, the babies are held in skin to skin for exactly 15 minutes. For others, the average duration of skin to skin was 37 hours of continuous skin to skin contact. And the control group,
so these are randomized controlled trials.
Yeah, so these are randomized controlled trials. So what we wanted to do is randomize people to the treatment versus a control, and then comparing the outcomes in order to find out kind of basically what works best. What are the effects of the treatment versus the control? And that will give you information about the potential benefits and risks of each. And I mean, it's worth noting, none of the studies looked at potential risks. They were only measuring potential benefits. So, but basically they're comparing very different things. 15 minutes of skin to skin versus 1 or 2 hours of skin to skin versus continuous skin to skin for 37 hours after birth. And they're comparing it to different things. So in some of the control conditions, they actually did have some skin to skin contact, but it was of a shorter duration. In others, the baby was taken away for 12 to 24 hours. And, you know, so we're not, you know, it's comparing different things to different things. So it's very difficult to draw any kind of clear conclusions from this kind of research. And there's other issues too, more generally, with skin to skin research, because I'd love to know what parents were actually told going into these studies. There's no information about this in the papers that I've been able to find. Because what you can do as well is you can create expectancy effects. So if you were told, we want to do this intervention because we think it's going to help you to breastfeed, then you go into it believing that you're getting an intervention that will help you to breastfeed. And that may mean that you are, one, that you feel that there's more pressure on you to breastfeed and that you ought to breastfeed, or two, that you expect it to happen and there's a kind of placebo effect based on that expectancy. Or if you don't get it, you feel like you've missed out on something. And does that impact your ability? Does that impact your confidence? And does that impact on your intention to breastfeed? So I kind of don't really know. And of course, the other thing is that the staff in these trials, it's impossible to blind. So in randomized controlled trials, we usually want to blind both the researchers and the clinicians involved in the trial and the patients involved in the trial to what drug they're receiving. So what you do is you give, if you were doing a trial of one medication versus a placebo medication, you would make the placebo and the real medication look identical, and the people giving it to the participants in the trial and the participants in the trial would not know what they were getting. You can't do that with skin to skin. It's not possible. So you will have a kind of expectancy effect. You also have things like researcher allegiancy. So if a researcher really believes that an intervention is going to work, they communicate it in the way that they talk to people. They communicate it and they create an expectancy effect. So that can affect the result. And what's also acknowledged in the Cochrane review itself is that they found bigger effects of skin to skin in smaller trials. What that kind of suggests is that there may be publication bias going on too. So if you do a trial, you do a small study and you don't get the results you're hoping for, that's often quite disappointing for the researchers, especially if they have a kind of allegiance towards skin to skin. So they may not publish those papers. So what you get is a research field of publications that are skewed towards the positive findings.
So you've covered the studies really well. You've gone into a lot more detail than it seems any others have around skin to skin. But what did the Cochrane reviewers find, ultimately, having looked at that?
So they were looking at results in 3 areas: health outcomes, the bond with the baby, and the success of breastfeeding. Basically, health outcomes, they didn't find any evidence to back up those claims, or they didn't find sufficient evidence to back up those claims. They didn't find sufficient evidence to say that skin-to-skin contact impacts the bond or the relationship between a mother and a baby. They found what they describe as weak evidence. I would describe as weak and very unconvincing evidence that skin to skin might impact breastfeeding. Now, the studies in that were a little mixed. Generally, they found that skin to skin was associated with initiation of breastfeeding, but a lot of the studies did not find an impact on continued breastfeeding. What you also find is that in many of the studies, the mothers who were holding the baby in skin to skin were also specifically offered help with breastfeeding. Like, can we help you latch your baby on now? If the baby seemed ready to feed, which you couldn't do if the comparison group was 12 or 24 hours of separation. So, I mean, surprise, this was the group that were more likely to breastfeed. Was that because they were specifically holding their baby in skin to skin? Or was that because they were with their baby more? Or was that because they were being advised and encouraged to initiate breastfeeding by healthcare staff who really believed that skin to skin might improve breastfeeding? So we're very enthusiastic about it. So I don't feel like the evidence there is really strong enough. And there were some studies that found an effect on longer term breastfeeding. Again, I would interpret very cautiously, because is it that kind of initial skin to skin contact, or is it also that if you're having that and you're also being told that this is really important and helpful for breastfeeding, and the staff are giving you a lot of encouragement about breastfeeding, does that in itself, that kind of breastfeeding promotion, impact mothers' decisions about how to feed their babies on an ongoing basis? I don't think it's conclusive, let's put it that way. And in fairness to the Cochrane reviewers, they don't say it's conclusive. They say they acknowledge the evidence is weak, but they make a recommendation that skin to skin should be advised to all mothers of healthy term babies because there's an absence of evidence of harm and there are potential benefits.
So about the lack of evidence of harm, is that true? Is there no evidence?
No, that's not true. So Joel Bass, who's a pediatrician in America, has done some work and looked at the potential impact of skin to skin on some adverse outcomes. One of those is something Dr. Clay Jones referred to in his interview with us, is sudden unexpected postnatal collapse, which is essentially when a healthy newborn baby is found no longer to have collapsed, and in some cases died. In other cases, they can be resuscitated, but they have essentially suffered a collapse and a serious health event.
And which can lead to brain injury.
Which can lead to brain injury, yeah. And that has been, there is some suggestion that skin to skin may contribute to that. And to me, intuitively, does that make sense? Given what we're told the rest of the time about holding a baby safely, we're told when we put our baby to bed, they should go on their backs, they should be on a firm surface, they should not have loose blankets around. And then in a postnatal setting with a mother who's tired and in pain, possibly on pain relieving medications, possibly experiencing medical complications, we're going to put a brand newborn baby prone on the soft surface that is a mother's breast, and a mother who may be just not in a great shape because she's really sleep deprived or she's in a lot of pain. I mean, this is not really making a great deal of sense to me. I think we need to kind of take a little bit of a step back here. Is this good advice? Could it be implicated in SUPC or sudden unexpected postnatal collapse? I think that's plausible. Clearly, there are other people who think this is plausible. I think there's big questions to be asked. And the other thing that Bass and his colleagues have highlighted is the potential role of skin-to-skin contact in neonatal falls. So basically, when the mother is so exhausted, she drops the baby, and that, of course, can have catastrophic impact on the baby, leading to potential brain damage and worse.
Yeah, so I wasn't aware of any of that. But then in 2020, HSIB, the Healthcare Safety Investigation branch who carry out patient safety investigations, they published a report looking at some cases in the UK of sudden unexpected postnatal collapse associated with skin-to-skin contact. So that had been flagged up to them, and so they did one of their national learning, it's called investigations reports, and it was a small number of cases, but there were a small number of deaths and cases of brain injury. So I remember when this report came out, I probably saw it on Twitter, as I see most things, and I remember thinking, oh my goodness, what HSIB found. Are we going to finally have some sense on skin to skin and on that baby friendly? But this report on the first or second page, there's baby friendly all over it. Baby friendly wrote the foreword, there's kind of baby friendly endorsement, baby friendly logos. So it kind of straight away was clear it was not going to investigate skin to skin itself as a practice whereby the risk potentially outweighs any benefit. It was looking at, are there some risks that we can mitigate? So that was really shocking to me.
I think it's also worth saying that in the intro to the HSIB report, they cite a lot of claims about the benefits of skin to skin, which is taken from the baby friendly website, the claims that they're making. And they say that the Cochrane review supports all of these claims. So it supports that it improves bonding, that it initiates biological reflexes, that it temperature regulation. And they say that the Cochrane review supports all those effects. And in fact, the Cochrane review didn't find sufficient evidence to support those claims. and made a recommendation that skin-to-skin contact should be recommended because it might have benefit. There's weak evidence of benefit on breastfeeding rates, and because there's an absence of evidence of harm. That's very different from saying it has all of these tremendous benefits.
I think they said in the HSIB report, and I do think this is just lifted from Baby Friendly because I've seen it there. A Cochrane systematic review has shown through randomized controlled trials that skin-to-skin contact in the first hour after birth, and then this list of benefits that I mentioned earlier, and you talked about, you know, regulating the baby's heart rate and everything. So it's saying these were proven by the Cochrane reviewers through randomized controlled trials, but that wasn't the case. They were discussed as kind of hypothetical benefits or the kind of background context to this intervention. Is that a fair way of putting it?
Yeah, they completely misrepresent the Cochrane review, actually, in that report, which is pretty alarming when it is an organisation supposed to be looking at patient safety and reviewing potential mistakes. You know, Baby Friendly are strong advocates of skin to skin. They've made all of these claims. They are in every UK maternity hospital. They have changed UK maternity practice with this emphasis on skin to skin. They've made all these claims. So number one, HSIB have completely misrepresented the findings of the Cochrane review and done so in collaboration with one of the biggest promoters of skin to skin in the UK. And that's a little bit like inviting me to review my own restaurant or mark my own homework. It's very difficult to say, well, actually, this practice doesn't have the benefits that are being claimed for it. I find it staggering that HSIB misrepresented the Cochrane review in that way. It kind of tells me they haven't read it. They've just kind of taken this for granted. And then what was their conclusion?
So they ultimately made recommendations that skin to skin should continue and because of all these amazing benefits, which we just discussed, but it needed closer monitoring. So the problem was that skin to skin was taking place at a time, you know, on postnatal ward when midwives and other staff caring for mothers have just delivered the baby and are now, you know, have a lot of jobs to do, and you know that a lot of these instances of skin to skin being implicated in sudden unexpected postnatal collapse, HSIB found there was a kind of lack of monitoring, or no one had noticed the baby's change in condition, and the mother couldn't see the baby's face and things like that. So they ultimately made recommendations that it needed closer monitoring and parents needed education on how to protect the baby's airway when doing this. But like I said earlier, there was never any suggestion that the practice itself might introduce risk that parents aren't willing to accept, or that the risk might outweigh the benefits. And I just found that really shocking.
I did too, because they were also suggesting things like women were having their babies in skin to skin while they were being sutured, while they were on Entonox, and it's like, what do we do? Why would we do that? Why would we choose to do that? I think, well, you choose to do that because you believe skin to skin has many, 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 many benefits, and I think it actually. Women are encouraged. I mean, certainly that was my experience. I was being encouraged to hold my baby where I felt weak and shaky, and was just not something I was prepared to do. I think these guidelines so overestimate the benefits. They're so disproportionate to any possible, even the most generous interpretation of that evidence, which I think the reviewers made, does not suggest that you should be doing this in the event that there are other considerations that would make it unsafe, or that you should push the boundaries of what you feel safe and comfortable doing. So I find it staggering, actually.
And I was going to say, I don't think it says anywhere in the HSIB report or guidelines that have followed it, that parents should be informed of these risks. So,
No.
you're still telling parents, do this thing, it has amazing benefits, but let me just show you how to do it safely. Well, is that a parent making an informed decision?
This has now crept as well into the NICE guidelines. So the new NICE guidelines that literally have just come out. We put a link. So we're recording this in early October 2023. These guidelines came out, what, a week, 2 weeks ago, something like that. A few days ago. And they're basically, one of the things that has been added is that skin to skin should be monitored. But it doesn't say what for. It doesn't say how. And the fact that you're saying it has to be monitored implies there's some risk to monitor. So what is the risk? And are parents going to be told what that risk is? And are parents going to be given a realistic assessment of the benefit, which is there's some weak evidence, which is really quite inconclusive, that maybe it might help with breastfeeding, possibly, compared to taking the baby away for a very long period of time. And I don't think total separation for a prolonged period of time is something that most parents would choose.
No, although we would obviously get accused of that sort of thing at IFA.
Oh yeah.
You advocate for newborn nurseries. So you mean you want all babies to be separated from their mothers at birth?
I think newborn nurseries are a great thing, right? And I think what should be the case is that we should trust parents to decide how much. We should trust parents to decide whether to use a newborn nursery and how much to use it. I don't think there's any evidence to suggest that sending your baby to a newborn nursery for a few hours while you get some sleep, content and safe in the knowledge that your baby is being competently cared for, is any kind of threat to your bond with your baby, or even to breastfeeding. I mean, clearly there's a biological reality that you've got to stimulate the breast to produce milk, okay? And if you take the baby away for a week, that's not going to happen, okay? But to take the baby away for a few hours, I don't see there's any evidence that would be harmful. And I think when you look at a mother's needs, the potential to get some uninterrupted sleep may have some advantages. And of course, that's not the only option. People might have the baby's dad, grandparents, aunts, uncles, their close family friends might want to get involved in this.
I think we'll do another episode on newborn nurseries and rooming in.
Yes, we should.
Yeah, but you talked about bonding and attachment, which, as I know, something you have a great interest in, and particularly the claims made in this area. And I as well find them the most egregious of the claims made about skin to skin and other aspects of the baby friendly initiative.
So, most of them haven't understood attachment theory. So attachment theory is a theory. Was originally proposed by John Bowlby. It's a scientific theory, okay, and it hasn't. I think this is the other thing. A lot of people don't grasp about attachment theory. It hasn't stayed in stone. Attachment theory has evolved. It's a whole kind of branch of research, applied in multiple areas, but there's a lot that I think Bowlby didn't get right. I think he's very culturally bound as well. He was viewing it through the lens of a kind of British 1950s context. But what he proposed was quite radical in his day. He really proposed that human beings were driven to bond and to connect with each other, particularly babies with their caregivers. And he proposed this was a biological drive, like being hungry or thirsty. You're driven to eat, you're driven to drink, you're driven to connect. And I think that bit he got right. Okay, I do think that is a kind of innate human thing. I think it looks different for different people. I don't think we should be overly prescriptive about it. But I think he was right that humans are driven to connect. I cannot see that putting a baby grow on your baby is going to threaten that innate drive. It is stronger than a baby grow. It is stronger than a few hours in a newborn nursery. So yeah, I mean, that's what he got right. I think one of the first aspects of attachment theory to be challenged was Bowlby's idea that a baby had a primary caregiver. What became very evident in observational research was that actually babies form multiple attachment to multiple people, and probably that's protective. Yeah, it's probably good for a baby to have more than one good close relationship. So I think one of the most egregious aspects of current maternity policy is an emphasis on the dyad. It's excluding other people who were going to be absolutely fundamental to a baby's life and to their health and their well-being, become irrelevant. And likewise, the mother becomes nothing more than the kind of vessel to care for the newborn. It's quite dehumanizing in a way that, you know, no longer would you want to sleep or shower, you just want to hold your baby in the nude for an hour.
I mean, I really, sorry to interrupt, I really get that sense from the baby friendly language around it. It's really very much almost this idea that when you give birth, you sort of transform into a more animal state, and you will shed the trappings of being a human, and you no longer need to sleep or eat. And baby friendly actually caution against women having showers and interrupting skin to skin. And I agree, it's incredibly dehumanizing, but almost more so than some of the other ways we talk about maternity care being dehumanizing. It's literally wanting you to allow a kind of mammalian process to take place. And yeah, didn't happen to me. I was still me once
Absolutely.
my baby was born.
Absolutely. And it's you that your baby forms a relationship with. It's not some weird mammalian instinct. You know, and I even think, like, it really irritates me because I used to remember hearing this stuff, and I think I switched off when I was pregnant. I was just like, oh, this is just bullshit. You know, but if I really think about it, it's actually really appalling, because I forget other people are going to take this seriously, you know. And what is kind of known a little bit about attachment is that attachment styles develop in the first 2 years. They don't develop in the first hour. They don't develop in the first week. You know, it's about experience and consistency over time that develops a child's attachment to their parent, the quality of the relationship that they're going to have. And even then, you know, the original attachment theory thought that this early attachment became the blueprint for all other relationships. That's not the case. The evidence does not support that. People's attachment, we'll do a whole episode on attachment. Attachment styles change throughout the lifespan. They're not stable. And I think they're far better off thought of as a continuum rather than as distinct categories. But this idea that you have to do all of these rituals and all of these, this is the way and this is the only way you've got to do it, and you've got to hold the baby in this way for this long, it's so prescriptive for, I think, the one bit of this process that can be left to nature. And you know, I think parents can do this fine, and I think there are many ways of doing it, and it should be their choice. And I also start to get quite aggrieved in the sense of, you know, I said at the beginning, you have to have justification to make a health recommendation, because you're, particularly when it comes to something where you're starting to interfere with normal family life, potentially cultural practices, I think it's interference. You know, and I think, you know, as you know, I do couples therapy. This to me would be like going and sitting in a couple's bedroom and giving them detailed instructions about how to behave. Hold in this position for this many minutes. That's how you form a connection. Or like going on a date and saying, do this, look in their eyes for this many minutes. It just gets silly, you know, it really gets silly.
I always say you can't prescribe love. I mean, you can't prescribe how to fall in love. It's a ridiculous idea. But you know, exactly. Baby friendly, do this all the time, you know, bonding and attachment.
Yeah. And of course it gets beyond that, because if you have problems with breastfeeding, if you have challenges breastfeeding, what's the advice? Skin to skin, more skin to skin, more skin to skin. And this is when the baby's older. Well, there's no evidence of that at all. You know, and hold your baby, yeah, absolutely. But I think this kind of bossiness and interference is, I don't think it's helping, and I don't think it's justified.
Yeah, I mean, we talked about some of the more serious risks, so they're very rare. But something we do hear a lot at IFA is mums who haven't been able to do skin to skin for whatever medical reason of their own or their babies, sort of having this terrible anxiety and shame about that, and fear that they might, you know, their bond with their babies being affected. And that just strikes me as so cruel, and an unintended consequence of this.
It's something I get private messages about on Twitter and social media, from people with small babies saying, I don't think I'm doing enough skin to skin. I'm really worried about my relationship with my baby, or I wasn't able to have skin to skin because I was having a really severe hemorrhage and I was rushed off to theatre and I was separated from my baby, and now I can't breastfeed and I'm terrified because it's going to affect my bond with my baby. And it's heartbreaking because that's a woman who's experienced a serious medical emergency, and who quite possibly hasn't been able to breastfeed because of that emergency, because a hemorrhage can, for some people, really affect their milk supply, then somehow blaming herself for those things, and also believing that that is going to affect the quality of the relationship she has with her baby. And I think it is unspeakably cruel that we have created a situation in which the advice of healthcare professionals and health authorities is leading women to feel that way. It's completely unjustifiable. I think, I think what would most benefit is actually not to worry. The problem here is women's anxiety about their bond with their baby, not their actual bond with their baby. And if baby friendly and healthcare professionals are contributing to that anxiety, shame on them. Shame on them. Because, my view is that I look at this and I think it's much more akin to a religious conviction than it is to scientific evidence to make particularly claims about bonding and lifelong health impact and the microbiome and epigenetics and all the other buzzwords that you can throw in. That's not science. That's not evidence. That isn't the basis of a healthcare recommendation. I think this is really the intrusion of ideology and morality. Actually, this is the right thing to do. This is the proper thing to do. This is how it ought to be done. And it's an intrusion of that into healthcare, and an intrusion of a particular way of seeing the mother-baby relationship, which probably doesn't hold in multiple cultures. I'd love to talk to people in this podcast from different cultures or who have experience in different cultures about what this advice looks like to them, because it really is so intrusive and not justifiable.
I agree. Yeah. So Ruth, just to check, are you saying parents shouldn't do skin to skin and they shouldn't have a choice about how they hold their babies after birth?
Well, number one, I think healthcare providers who are now saying skin to skin needs to be monitored actually need to get clear with parents as to what the risks associated with skin to skin are and what they're monitoring for and why. And then parents can decide if it's something they want to do. But I think all parents are going to want to hold their babies. That is, that's attachment theory 101. We are driven to connect. So parents are going to want to hold their babies. I don't think you need to tell them to. Okay. I think beyond advice about how to hold a baby safely, if that is needed, hold the baby however you want, for as long as you want, as feels comfortable, as feels sustainable to you. Whether the mother should hold the baby or the dad or a grandparent or an aunt or uncle or a sibling, I think this should be down to the family to decide for themselves. I just don't think there's a need for healthcare professionals to intrude on this. I don't think there's sufficient evidence to justify any kind of advice beyond what is necessary for safety. I think it's reasonable to tell parents not to hold a baby prone, or not to put a baby on that tummy if they can avoid it, or not to travel in a car without a car seat. But other than those kind of basic safety advice, I think we should leave parents to do what it feels good to them, what is culturally acceptable to them. and really what they want. And I think parents can be trusted. I think one of the biggest aspects of this, I see this as a sort of idea that interventions, medical care have somehow interfered and made people incapable of having human instincts and of being able to care for their babies. I actually think it's a fundamentally very negative and very patronizing view of parents, particularly new parents. And look, I think when you have a new baby, it is a new role for most of us. Most of us are not spending huge amounts of time around small children because of the way we structure our family lives in the UK. You know, some people do live in extended families, but most people in the UK don't live in extended family. So, you know, it is a new role. I think that can feel overwhelming because you're not used to it. There is a period of getting used to that kind of newness. But I also think, you know, let's go back to attachment theory. If these people want to talk about attachment theory, let's talk attachment theory. Actually, this healthcare advice violates a core principle in attachment theory, which is the principle of non-interference, which is that you don't go and interfere. Okay, you let people figure things out by themselves because that's what gives people a sense of competence. It's what gives people a sense of their own autonomy and their own freedom. And I think we're violating that principle in maternity care.
Yeah.
In many ways, but especially here.
And it also undermines trust in healthcare professionals. If we see kind of dubious advice, overbearing advice that, you know, actually might not be based on the best evidence, then, you know, you end up with people withdrawing from healthcare professionals, not trusting them.
And I agree with you, because if you are saying alongside vaccinate your baby, use a car seat, put your baby on their back to sleep, if you don't hold your baby after birth immediately for an hour in the nude in a prone position, it will threaten your baby's microbiome and epigenetic potential, and it will impair their neuroendocrine system and affect their bond with you for life. I think most of us intuitively know that's bullshit. I think we do. Let's just not put too fine a point on it. And I think when you realize, when that advice is given by the same people telling you you should vaccinate your baby, use a car seat, how to sleep safely, what do you take seriously? You know, I think it's a serious thing for a healthcare professional to make recommendations. Okay, let's ask one hypothetical question to end this podcast on. If I could put you in a magic time machine and take you back to that 2 hours of skin to skin, and you could step into the room where it was happening, what would you say? What would you do?
Well, I would tell myself to sleep, but probably to do that, I need to tell myself to trust my instincts. But if I think I'm desperately in need of sleep, and that is going to be the best thing for my family, my instincts are probably correct. They're not selfish. I'm not failing to enact crucial processes for my baby. So yes, okay, it was only 2 hours, but it kind of set the tone for what was to come. I was very compliant with all the advice, and a lot of it really worked against my family. I know I'll probably talk about my experiences with infant feeding in another podcast, but I would tell myself, you know, trust your instincts, sleep, pass the baby to her dad, who's, you know, right there and willing to meet her, and you know, this is outside the realm of this discussion, but I'd probably tell him, you know, give the baby a bottle, let me sleep as long as I can. How about you?
I would tell my partner he can put his top back on if he wants. And I think I tell the midwives that they've done a great job getting her out safely. Thank you. And your work is done. And we've got this. We'll take it from here. And I think my biggest message would be, they've got this, and you need to not interfere. You need to leave them, because they're fine. They're going to do just fine. Thank you so much. If you made it to the end, please, please, please help us out. Hit the like, subscribe, leave a comment, let us know what you think. Good or bad, we're open to all feedback. Take good care.